Good morning. Hello. Welcome, welcome, welcome to another Family Caregiver Talk with Aging Advantage. And I am Donna Mitchell, your host for today. And as always, just letting you know that Aging Advantage is a nonprofit organization that helps support seniors and disabled adults in the greater St. Louis area. Through the local grants and donations, we are able to provide these educational talks to our clients and caregivers. And today, our speaker is Jennifer Martin, and she will share a little bit about the understanding of pain, mobility, and aging. Dr. Jen, good morning. Hello. Thank you so much for coming on today. We really appreciate you. And I'm going to allow you to have your floor. And once you're completed, I will be back and we can, answer any questions or have discussions. All right. Here's your floor, Jennifer Martin. There you go.
Thank you, Donna. I appreciate it. And hello, everyone. Nice to meet all of you. So like Donna had said, today, what I want to share with you guys is really a little bit better understanding about pain and how it can affect mobility and just the overarching, I guess, consequences that it can have, good and bad, right, on our aging. And more importantly, I think as we age, just for caregivers and for family and just seniors, also, what is normal and what really is not normal, and what also can we actually improve upon. Right now, we're going to be doing the part one of this, and then we're going to be doing part two of this kind of presentation to get a little more granular into some of the topics as well. So this will be like I said, part one. So first of all, let's start out with why does this even matter, right? In caregiving and just case management in general. So pain, as you guys know, is one of the top drivers of functional decline. So with that being said, as people age, a lot of times, we can get arthritis, different kind of conditions like that, and they can cause the body to deteriorate, and then you obviously start having more pain, and then you start moving less consequentially. And then a lot of times also for people as they age, then cognitive health starts to decline, outlook on life starts to decline, and then it's just kind of a whole slippery slope that then can affect all the different areas of life, unfortunately, for patients. So pain also is going to lead to reduced mobility, as I said, just because moving around is going to cause more pain. But one of the big things that I think we all need to recognize too for these patients is that they then understand that if they move, then it's going to cause pain. But what happens then is that over time, they will sometimes then acquire like a fear of moving. So instead of just, okay, I'm going to get up and I'm going to walk from over here to over there, they're afraid to do that. Sometimes also balance, proprioception, other things can factor into that as well, which we'll discuss later. But it can really literally be crippling for some of these patients physically, but then also the mental toll it starts to take on patients as well can be really daunting for them. So caregivers a lot of times will just hear, from family, sometimes even from the aging individual, like, okay, this is just old age. Like, I'm just getting old. Like, this is what happens. It's just how it goes. And yes, there are some things, this is just what happens. However, there are other conditions and types of symptoms that we can actually improve in different ways. So a lot of the changes are attributed to aging. Like I said, we can modify them. So sometimes we can look at our ergonomics, we can look at biomechanics, we can look at what are the resources from a biopsychosocial standpoint that this patient has to help improve their mobility, to help keep them moving, keep them going, and to most importantly for them, make it safe, which is key. So understanding how that pain, can can be decreased potentially, but like I said, looking at what resources do they have access to and maybe getting them referred to the right type of provider or the right type of care, and partnering with them and their families to make sure it is a safe environment for them. So a lot of times, education, like what we're doing. So thank you guys for doing this and all the things that you do. But education can really help not only us as caregivers, and us as case managers, et cetera, but also for the patients too. So it helps us to recognize what is suffering and what can be improved, and helps to empower everybody, to really like step in and help. So early identification obviously is better. The I'm all about being proactive. So the more we can get a better, clearer snapshot of what are we working with right now, and then where is this going to go? What kind of resources, what kind of support, does that patient need to get through? Sometimes, they have a little incident, or, kind of a flaring of their pain, their symptoms, or some new diagnosis potentially. So we have to kind of look at, all right, how do we pause, and how do we address the situation where we are now? But then the 2.0 of that is, what does this look like down the road for this patient? What does this look like for their family? What does it look like for their environment? And really to also focus on those resources and really setting those people up, proactively for success, so that when the time comes that they have to, like something progresses worse, or sometimes even, maybe it gets better. But they already have those kind of resources in mind, and they already know what is going to be those next steps. It really helps to take a lot of the anxiety, off of the patient and off of the families as well. And it just makes it a nice, smoother, in medical, we call it continuum of care, but a really nice, smoother transition into what that next phase looks like for the patient and their family. So obviously, like I said, goal is we're just going to kind of look today a little bit about what's normal aging, what's treatable, and then what can we do with some of those things. So we're going to start with the aging versus deconditioning. So aging, as we all know, gradually occurs, and it's just physiological changes kind of that happen within the body. That is different than deconditioning. So as we see here, this lovely older guy, he's just hanging out in his chair, eating some donuts, watching some TV. Usually they're in a recliner. But, what can happen as patients get older, again, some of it is just that mentality of like, okay, well, I'm just getting old. Like, this is what it is. This is what it's going to be. Nothing I can do about it. And then when we kind of start seeing sometimes that mental decline, we start seeing the patient and their family also. I don't say like, half give up or give up, but they're less likely to want to continue engaging in being active. And then we will see an increase, in illness, or increases sometimes in the progression of their, conditions. And obviously, as we all know, the mental component of it and the psychological component of it can really drive and have a huge impact on their physical health, physical outcomes, etc. So deconditioning can happen pretty quickly, days to weeks. So it's interesting, even with this, not talking about aging population for a second, but even in Olympic athletes. So when we look at our sports athletes, they will say, even for themselves, like if they haven't done, like if they get sick or something, or they have an injury and they have to be out for a little while, even just a couple, like 5, 6, 7 days, couple weeks, they will start being able to see massive decline in their ability to perform. And it's just, it just can happen that fast. And so when you couple that with just the natural aging process, patients can go downhill, fairly rapidly. So we just kind of have to keep these things top of mind. So their muscle kind of muscle strength, the balance that they have, kind of that proprioception coordination. We'll talk about that a little more later. And their endurance can really rapidly decline, especially if they're on bed rest. Also, I lovingly call it recliner rest. So some people, they will get to where it's like, okay, well, they're mentally like, okay, well, I'm not like going to be in bed all the time. So they and then their family don't necessarily put themselves in the, you know, in bed bucket, right? But instead they are hanging out in the recliner like 22 hours a day or something. It's the same. If you don't use it, you lose it. So if these people aren't up, they aren't moving, even up seated in a chair, moving around and stuff like that. But if they aren't actively moving around, you're going to start seeing all that kind of start to decline. The deconditioning part sometimes is reversible. So, but there are other aspects that we can get back that we'll talk about. So a lot of older adults too are, mislabeled as frail. And usually we get that more with our little tiny older ladies that get little osteoporotic, and they start getting that hunchback, kind of leaning forward with the osteoporosis. And again, like, yes, we need to be careful with them. If they do have, more brittle bones doing some of the activities, etc., we want to be a little more cognizant of them with fall risks, etc., doing stairs, things like that. But even at that, we have to still keep those people strong. We have to keep them moving. We have to continue to put load onto the bones so that the bones then can continue to strengthen internally, etc. So they can kind of keep, what they do have, at least as they continue to get older. Also, another thing I'm just going to insert here real quick with the frail. As people get older, also sometimes we see this a lot, like sometimes with falls. Patients can, they can get fractures, unfortunately. And one of the fractures that they can get is actually, it's called a compression fracture, where they will have one of their vertebrae in their spine will actually, for lack of better terms, called like squish. So kind of like if you had a marshmallow, nice and big and puffy, and you kind of just squished it down with your hands. Instead of the bone being like that nice, full, robust height, it's that vertebrae of that bone in their spine will actually kind of squish down, and kind of internally fracture. And obviously that's going to cause a lot of pain, a lot of inflammation, for these patients as well. Some of these patients might not be able to stand upright and might not be able to move and function and stuff like that. Over time, that will heal, either, with intervention, or just the body kind of stops the inflammatory process on it. But things like that can cause a lot of pain for patients. And also, even the fear of those things can cause patients to be a little more cautious. But again, it's like we need to recognize it, yes, but we still need to be able to have processes and systems and things like that put in place to help the patient kind of move past some of those things. Care plans, obviously, like we were talking about, should address like activity tolerance. Obviously, you don't want somebody that can't go up and down the stairs at all. Like, we're not making a care plan where we're doing that 5 times a day. Completely unrealistic, completely, just not safe. And plus, too, back to the psychological component for these patients, like, we want to make sure we're giving them wins, right? We want to make sure we're kind of positive reinforcement, right? Think of it like that. So, we want them to have good experiences when we are having them try to move, try to do some strength training, and just kind of build their balance back up, and even just trying to keep their walking where it is. We want all of that to be a positive experience. And so we don't want to like push someone way past what they're going to be able to actually do, because then it can start that negative cognitive situation. So Okay. Next thing we're going to talk about, I keep talking about muscle and that strength. So let's talk about what happens with muscle, as we age. So there's this lovely word called sarcopenia. And basically, that just correlates to muscle loss with age. So keep it nice and simple. We have this little picture here on the right hand side. This picture here on the left, that's a nice big thick, regular size of overall muscle fibers. What happens as you age, you will lose about 3 to 8% of that muscle mass per decade, starting at age 30. So again, for all of us younger people still yet, you got to get on this when you're younger. Start trying to continue to build your muscles, keep your muscles that you do have, because you have to work at it more, unfortunately, as you age, to be able to just maintain where you were yesterday. It's really fun. But anyway, so for older patients, though, we got to be aware of this. It just happens. But as they say, and I'm sure some of you guys have heard this, that your muscle strength and the amount of muscle mass you have now, they're realizing, is a huge indicator of your actual, kind of your physiologic age, right? And it also is a good indicator too of your overall health and your overall kind of health trajectory. So for patients, this is kind of something that we need to keep in mind. They're not working with the same kind of equipment that we are. They just literally have less muscle mass, unfortunately. And again, we see here that it can accelerate pretty dramatically after the age of 60, especially into a patient's 70s, 80s, and beyond, without them having some kind of actual resistance activity. So that's where, sometimes for the older patients, like bands can be safe, and other things like that like PT and sometimes PT can do with them safely, just even like at home, which is nice. They will, because of this lack of, muscle, it's going to, obviously, they're going to be a little bit weaker. Yes, they're going to be a little slower when they're walking, because they just don't also have as many muscle fibers actually firing when they're going to walk and move. Also, though, you got to think too, when they're going to pick something up, they can't pick up something as heavy as they did before. They're going to also have more fatigue because they don't have as much muscle mass. But what happens when you have more muscle, you're going to have more blood flow, also more oxygen, more everything infiltrating that muscle tissue to help keep you going, and keep you moving. But if you have less muscle, less blood flow going to the muscle just in general, less oxygen, less everything happening, from a conditions standpoint, for the conditions to be right, for that patient to be able to keep moving and keep going longer periods of time. So that's where they're going to have more fatigue, unfortunately, sometimes. So obviously, this is going to increase the risk of the falls, like we talked about, and then stress on the body. It's going to also impact their activities of daily living, like we were talking about, their stairs, even when they're trying to do transfers from like the bed to a chair or to a wheelchair or to a walker, sit stand activities. They're just going to need to take it a little slower and just be a little more cognizant of just of their body and kind of, what's happening with it. And, we're going to push it a little bit, but not too much. So also here we see that muscle loss is going to affect their posture and spinal loading, kind of like what I was talking about a little bit with the osteopenia. That's kind of more a bone related issue. But I'm sure we've all heard the term, your core muscles. I worked on my core. Like that's great, and that's where a lot of some of this comes in here with your postural muscles and the spinal loading. So as patients also get older, right, we see that they will kind of start to hunch forward. I have a picture of this later, I'll show you guys, but they'll start to kind of lean forward a little bit more, and a couple fold reasons why that will happen. Like I said, obviously you have those discs degenerate, in their back, those bones get closer together and they kind of just start fusing into that position. But also, when you're, again, when you're not using it, you're losing it. So if they're not doing activities where they have to be upright, and standing up straight, or even sitting up straight and engaging their abs, engaging their back muscles, etc., to help keep them upright, those muscles are also going to decondition over time. So strength training obviously is helpful also, but like we said, we need to make sure it's safe, and we need to make sure it's safe for the load that they can tolerate from a bone standpoint, also a joint standpoint, like ligaments, tendons, and all the fun things that can also live in those areas as well. So talk about muscle here for just a moment. So we have several different types of muscle in the body. Primarily, we have your skeletal muscle, you'll see here at the bottom down here. You have your smooth muscle, and then you have your cardiac muscle or heart muscle, right? The thing with these is this skeletal muscle on the left-hand side here. This is primarily going to be supportive of all the activity that you're doing. So you're moving around, you're basically, like I said, all your activity types of behavior stuff. You're walking, you're picking something up, sit, stand, all those things. Those are going to support your joints, and then also your balance, and like I said, kind of some of the proprioception, your course correcting. Like if you feel like you're going to start falling over to the right, that smooth muscle will engage, and then it will, your muscles will tighten, fire, and then it will help bring you back to the left, so you're not going to fall over. So that's kind of the function of your skeletal muscle. Cardiac muscle over here on this right hand side is your heart muscle. And as we all know too, that, like, why do people do cardio? That's because we need to also work out this muscle to make sure that your heart muscle is staying nice and strong, even when you're younger, but also, as you age. So the strength training part is good, but we also, might need to take a couple laps around the house, or, walk a little bit outside or do something. Sometimes, even I know for older people, like we'll have them do the little seated bike pedaling things, just something like that to kind of just get the heart rate up, get the heart rate pumping, and making sure that cardiac muscle is also functioning and firing, so that doesn't decline from the functionality standpoint with that too. Respiratory muscles, obviously, they're going to affect your endurance. So obviously people don't think about that we have like our diaphragm underneath our lungs, right? So same thing. When you are doing some cardio and you're huffing and puffing, that's a good thing, because it helps to make sure that we're also engaging some of those respiratory areas in around our lungs, to make sure that all of those can move well and we can get oxygen in and out how we need to. So here we see that core muscles, stabilize spine and pelvis. We talked about that a little bit, and we talked about a little bit kind of what that core is. Now, this pelvic floor muscles is interesting. So I'm going to talk about this for just a quick second. A lot of us have heard pelvic floor and we're like, what is that? What does that actually functionally do? So pelvic floor for males and females can be an issue. Everybody has them, obviously, which is good. But what they do is, when your pelvic floor muscles are the right type of tone, just a nice, good tone, you're going to have, a regular urgency to go to the bathroom. Typically, it's a little more, it's more urine related, but from like a urologic standpoint, but you're going to have the urgency to go to the bathroom, and then you can hold it until you actually are able to use the restroom, right? What happens though, for some people, especially as they age, the pelvic floor muscles can weaken also. So a lot of us have heard of the exercise, quote unquote, called Kegel exercises, right? Kegel exercises address your pelvic floor muscles. So when those muscles are weak, what happens is you have the urge to go to the bathroom, and then sometimes it's like, oh, oops, your muscles aren't strong enough to be able to like hold everything where it needs to be until you can go to the bathroom. So we start seeing incontinence issues. Sometimes, like some of the ladies will, and I mean, this could, I guess, happen to guys too, but like usually this is more a female thing. But like a woman will say like she sneezed and then she like dribbled a little, or something like that. Or if people like jump up and down, or just different things like that, you'll be able to see. Or they cough, you'll see that they'll have a little bit of urine leakage, and a little bit of incontinence that can go along with that. And on the flip side of that, though, too, sometimes pelvic floor muscles can be super, super tight and like spastic kind of. And then it will give the patient the sensation constantly like they have to go to the bathroom, like they constantly have to urinate. Almost like think like how a UTI would cause for a patient. So, it can be, it can be deconditioned, and it can also be like too like, I guess, too hypertonic, I'm going to say, like, so too much in spasm. And that's where working with a physical therapist, there are physical therapists that specially work on pelvic floor muscles, is great, because they can kind of help give the patient like those Kegel exercises. But there's some other things now that can be really, really great. There's different devices in medical device land. There's like one I know specifically is called like the PeriFit, and things like that can help the patient to be able to continue to train, right? Got to train the muscles, train those muscles also too. So really important. And I think it's not always talked about a lot, but obviously, I mean, this can absolutely mentally affect someone's confidence, etc. As they continue to age. So it's definitely something that needs to be talked about, I feel like, a little bit more sometimes than we actually do on the medical side of care. So the other thing in the middle here, we have the smooth muscle. Smooth muscle is going to affect your circulation, digestion stuff. So this is kind of like your blood vessels type of things, your, all your intestine stuff, your esophagus, etc. So as you age, also, smooth muscle can also kind of decrease in function. And we see this with older people having issues sometimes with like swallowing, right? So they can't swallow like a bolus or a big, chunk of food as easily potentially. And it's just because smooth muscle is supposed to contract and almost do like these waves. We call it peristaltic kind of contractions, but it kind of like does these waves of contract, relax, contract, relax, contract, relax. And that's how the food moves through your system when you put it in your mouth all the way to the other end. Your smooth muscle will do this type of process. Same thing happens, if you think about it like that, in your blood vessels. And, you get this contract, relax kind of mechanism where it moves everything through. And as we age, sometimes that type of muscle tissue also can decrease in function. So we hear, like I said, on the top end, I'll call it, we'll hear patients talk about, like food kind of just gets stuck. Stuff isn't moving as great as it used to move. They can't maybe eat like big chunks of steak or big chunks of stuff. They need to eat squishier, softer kind of foods. And to be able to get it down, or more sliding kind of foods to be able to get it down their throat so it doesn't get caught and stuck. And that's the upper part of it. The other part of it, the other end of it, we hear a lot of older patients, right, talk about they have constipation issues. And so that's where this kind of comes in play. But also making sure, that they have enough water in their system and they're hydrating enough to make sure to move that food through is key. We're going to see this also circulation issues with your varicose veins, just different types of basically different kind of vascular conditions where it can because things aren't moving necessarily as correctly, patients can get pain, they can get inflammation, they can get stagnation, etc. So again, the more though you move your body, so when you're up, you're moving around, um, it will then trigger also some of the smooth muscle and kind of all the muscle in your body, as we're learning, to kind of cue up and also to start moving. So like how they talk about when you eat, if you can walk, don't just eat and sit, right? You want to eat and move, go for a little gentle walk, move around, for like 10 minutes afterwards. Why? Because that also is going to help stimulate that smooth muscle category in the middle there for your digestion to continue to have those muscles engage and help you to digest your food a little more easier, especially if patients get kind of some constipation issues and things like that as well. So hopefully this makes a little bit more sense. But yeah, you want to do, conditioning with all of these different types of muscle groups. Not just, oh, let's do some bands on your legs today, Frank, great, cool. But we also need to look at some of these other muscle categories and just make sure that we're also engaging these as well as patients age. We'll talk about nerves here and kind of some of the nervous system for a moment. So this is where it can kind of get, we can get pretty granular with this. And on a 2.0 of this presentation, we'll do that. But for right now, we're just going to kind of talk about kind of high level of some of these things. And then I'll come back, like I said, in a different presentation and really show you guys like some videos of what some of these gait issues can look like and peripheral neuropathy, what you're going to see from the patient. Like, what are we looking for? What are you going to actually see the patient do? And then what do we do about it? How can we treat it? But like, what kind of resources then would we need to potentially get that patient then connected to from a treatment standpoint? But high level, so I'm sure we've all heard of diabetic neuropathy, right? Well, what is that? So that's when you start getting your peripheral neuropathies. Peripheral just means like your arms and your leg stuff, okay? Central would mean more like your trunk, like your head, chest, torso kind of area is more central. So peripheral just means like your arms, your legs, and neuropathy basically means you have like decreased sensation, decreased kind of feeling, decreased nerve function to that area. But that peripheral neuropathy symptoms we're going to see with that, then we're going to see sometimes like numbness. Like I said, they can't feel that sensory, right? Burning. Sometimes we'll also see usually numbness, burning. Occasionally you can have somebody that'll feel kind of like a pin prickly kind of a scenario. But yeah, usually you're going to be more numb, more burning. Like I said, common in diabetic patients, vascular disease, and this is also going to be common in aging. So reduced sensation, like I said, the issue with peripheral neuropathy is they just can't feel. So they can't feel the bottom of their foot when they go to step. They pick up whatever it is that they're picking up, and they literally might not be able to feel that they have it in their hand. So they don't know how hard and strong they need to grip with their hand to keep holding on to the coffee mug. So, it's like example, like the coffee mug example, start teaching them to hold it in your right hand with the handle, but put your left hand underneath of it potentially also. But when people walk from a gait perspective, they, like I said, they can't feel the bottom of their foot right. And so it doesn't allow then kind of those signals to go from the foot to the brain and back down to help you as the patient be able to kind of course correct, we'll call it, so that you don't fall over and that you don't have like balance issues and kind of, we call it proprioception issues when you're walking. So, but like I said, we'll go into that more at a different time because that's a whole thing in and of itself. But the issue is because they are not able to do that mechanism from a neurological standpoint correctly, it puts patients at an increased risk for falls. Um, and, and then obviously we know like issues in the neck the nerves coming out of the neck can affect the arms and the hands. Nerves coming out of the lower back will affect the legs and the feet. And so, again, we'll talk about this a little more, but we can't just assume always, oh, okay, it's an actual issue with this patient's foot. It's an actual issue with this patient's shoulder. We need to look at where does that whole entire nerve pathway travel, the motor part of that nerve and the sensory part of that nerve. And where does it originate? And could there be an issue possibly like back at the source, back at the spine, that could be pinching potentially and affecting some of these things as well. So early intervention obviously is going to massively improve the safety for these patients. Myositis is a really, really fascinating condition. It is basically like where your body is attacking its own muscle. So think of like almost like autoimmune, right? So it basically can account for these patients losing a lot of muscle mass. I mean, like almost like cancer looking levels of muscle mass, like losing 20 pounds in, a 3-4 month time period type of things if it's like active, or it can be like a longer kind of progressive process, but it's going to cause a lot of muscle weakness, obviously, and you'll literally see those muscles just like waste away. There's 3 different versions of myositis. Like I said, we'll talk about that more and what do you do about it at a different time. But yeah, just know that there's a lot of things like this that can affect patients. Joint degeneration and arthritis. We've all heard of rheumatoid arthritis. We've all heard of osteoarthritis. We might have heard of gout. As patients age, obviously their joint spaces are going to decrease. Pop this next slide here. The joint spaces are going to decrease, and then obviously you're going to get more rubbing, grinding, more inflammation in that joint space, more pain. We're going to go into this a little bit different also, but high level, I want you guys to see this so you can just kind of start understanding this. So progression, this is osteoarthritis here, okay? On the left-hand side picture here, see how there's like a decreased joint space in the middle? You're going to see the same thing over here on this knee on the very right-hand side, this grade 4, decreased joint space. So we're going to have like, this is a good one on the left, better one on the left, grade 1. We have all this nice black joint space. On the right-hand side, we don't have that on this grade 4. It's kind of a little more bone on bone here, as they say. But on this, back to this left-hand picture, progression of OA. So you're going to have a lot of decreased joint space here. That joint and those bones are kind of going to be grinding on each other. I like to think of them like this. Think OA, grind away, like bad, right? But you're going to grind those joints together. You're going to create inflammation. You're going to create pain. And then also you're going to decrease that overall joint space, be more bone on bone. So in these situations, more your OA, you're going to have this obviously be more like knee, more hip, can be shoulder and stuff. So this is a lot of times where our hip replacements come in, our knee replacements, etc., things like that. Progression of RA, this next little picture over here. So again, my little saying to remember the difference of these two. So think RA, nibble away, right? So see on the sides here of this joint space, it almost looks like a little mouse kind of came in and just like took little bites out of the sides of that joint. You have also the decrease of this cartilage in the middle, but you're also going to see kind of those little bites out of the sides of that joint. Obviously gonna cause some pain, gonna cause some inflammation, but you're gonna also see that joint swollen, but it's going to actually be a completely different mechanism somewhat that's happening on the inside than with your OA. So OA, grind away. You're going to be grinding away that joint space, and then RA, you're gonna nibble, you're going to be nibbling more the sides there, as well as kind of decreasing that joint space. So that's kind of the difference of that, and just kind of high level what that's kind of going to look like. So spine changes, obviously we know we got discs in between here. This is kind of a normal, nice disc height here. as you get the degeneration of the spine, which will happen as you age, that will decrease these holes in the back here, high level, where these nerves are trying to come out, these yellow things. And then those nerves can get pinched. And as we talked about, go backwards for a second here. We talked about here with this neuropathy, right? When patients can't feel things, or you right here, how we talked about the cervical nerves affecting the arms and the hands, lumbar nerves affecting the legs, and the walking and the feet. That's where some of this stuff can actually originate at the actual spine level. So, is it normal for things to degenerate? Yes, but however, we don't want to be having those peripheral neuropathy symptoms, and those sensory changes. That is not normal. We don't want to be doing that. So, this is just, again, we're going to talk about a little more of this stuff, different kind of presentation, but we're going to get, some of the bone spurs also. That's going to happen when we get that arthritis. Really high level here too. Two different branches of nerves that are going to come off the spine. So you're going to have your sensory branch and you're going to have your motor branch. You can, because of degeneration, again, aging process, etc., you can affect sensory. You can also affect that motor muscle component as well. And we're going to talk a little more in the future about what does that look like? What are we looking for? And how would you know? What would you do with this? So, pain, obviously, like impact on function. So here's this guy right here, how we're on the right-hand side with his little walker, how he's kind of hunched over forward. That's what I was talking about, that kyphosis, what we were talking about earlier. But obviously for patients, pain can alter how they move. It's going to increase their stiffness, increase weakness. They're going to have balance issues, potentially sleep issues, fear of falling. And, we just need to make sure to educate people as much as possible, caregivers, patients, etc., just so that everybody has a better runway, to be able to work with these patients and proactively help them age instead of them just kind of declining. So again, what's normal aging here versus like what's going to be more our red flags of like, okay, we might need to do something and actually get this checked out. So again, mild stiffness with rest, common. So again, like how we saw that kind of arthritis situation that can happen, the osteoarthritis situation, the OA, that, is going to just kind of happen to patients sometimes. Like as they get older, we're going to see some degeneration in that cartilage and joint spaces, etc. However, a little bit of mild stiffness is fine, but more exaggerated kind of pain, and a lot of pain with movement constantly is not what we want. That would be a red flag though. So they're going to have a little slower recovery than normal. They're going to have some occasional aches, normal, but progressive weakness, not normal. Like we talked about, increasing numbness. Again, they're not going to be able to feel the bottom of their foot. It's going to affect their safety, going to affect them, possibly more falls, again, dropping things, etc. Also with increased numbness, and decreased sensation, you also have to think about from a safety perspective, they're not going to be able to feel hot or cold properly either, guys. So they're going to be more of a risk of like putting their hand on the stove, or, if they're outside, like it's really cold outside here in St. Louis this week, really cold. But they're not going to always necessarily notice like, oh, wow, okay, yeah, this is really, really cold. I need to, remove my body physically away from this thing. So that can also be a safety issue, and a safety issue for some of these people like that, the more issues like that they have, them, again, living alone and cooking and et cetera, navigating things like that, things that we just take for granted on a daily basis can be a little bit more worrisome for them. Just them navigating their environment. So night pain with rest, needs evaluation sometimes, not always, please no, not always, but sometimes, this can be like a cancer or something like that is starting to begin begin to happen process wise in their body. Bowel bladder changes are urgent. So yeah, all these red checks are the what we need to definitely get checked out. Things obviously green's good, but back to that bowel bladder changes. Like we talked about, there is your pelvic floor issues that we discussed, right? But there are other bowel bladder issues that can actually be where the patient loses like bowel bladder function. Um, so like they literally are fine 1 minute and the next minute they're like fully like bowel bladder incontinent, especially if they're bowel incontinent, like immediate bowel incontinent, can be definitely concerning. There can be something neurologically going on, and sometimes that can be like originating from the spine. And sometimes that needs urgent looked at, like almost ER kind of urgent looked at times, depending on the patient, if they can't control it whatsoever. That's a gotta get checked out now situation. And again, frequent falls, definitely we need to be looking at these things as well. What's going on? Is it a proprioception issue, balance issue? Is it something bigger, neuropathy issue? Is it something, bigger that they have going on? Maybe it's something that could be in the brain, spinal cord area, etc. So we definitely want to get those things looked at as well. Transitioning to practical, a lot of the changes are manageable for patients. We can, like I said, we can catch this stuff early. We can educate and do the right things that we need to. Muscles and balance are adaptable. We can, like I said, we can try to train the muscles and work on balance issues, and give them patients different tools, walkers, the rollators, even like the double poles to be able to walk with, a cane. They might be comfortable with 2 canes instead of the poles for walking, whatever that looks like. But we need to just make sure that we're continuing to move. So, and again, pain doesn't always equal damage per se or irreversible damage. It's just, is there an inflammatory process happening from the grinding, as we learned, in that joint space, and maybe that joint space is just going to stay decreased. But how can we help with the pain? How can we help with the inflammation? And how can we get those down so that that can be improved, right? So the patient can continue moving. Early intervention is better. Obviously, caregivers are huge. All of our case managers, huge for you guys to be able to recognize these conditions and then get these people to the resources that can support them now. And like I said, also support them for what is this going to kind of look like down the road. Movement is good. And, and some of these tools that we can help give them too can help them keep their independence, keep them more mentally strong and more mentally positive, and that's huge as these patients continue to age. So in part 2 of this, the high level kind of version of part 2 of this, we're going to talk a little bit more about kind of some solutions that some of these people can kind of do daily, and things that we can do with some of these patients as well. So anyways, that is all for this presentation. I know that was kind of a lot, but just kind of wanted to just kind of warm you guys up to some of these different things. Like I said, like the different types of muscle, like that, the skeletal, the smooth, the cardiac. When we think of muscle, a lot of times we just think of, we just think of patients in terms of, we got to do some bands, we got to do some exercises, and really we need to think about the whole person, the whole body, and how we can support that instead a little more. So that is it for the moment. Thank you, ladies.
And thank you. That was great. Um, really good because all of that, I'm sure, it gives the caregivers and the clients or patients themselves um, more detail sometimes of what you're going through. Because sometimes, going through different things with your body, you just look at the surface of it, but getting in more depth and detail with things, it helps us to understand how to care for our bodies and as we age. So it was great. I appreciate it. Thank you so much, Miss Jen. And we will see you guys back with another ARPA talk at about 11 a.m., correct? Isn't that the time we're coming back?
Yes.
Okay. All righty, with part two. So, see everybody then. Time for a little break, and we'll see you soon. Thank you.
Thank you.